Now, our course of the FECO, I request Dr. Ragini Parekh, Dr. Navneet Tosniwal, Dr. Shirish Thorat, and Gopal. Dr. Gopal is there. Okay. So, we will deal with FECO emulsification in the different grades of cataract. And I have got the endowment lecture on Daljit Singh in Hall 3. So I will be presenting my presentation with the consent of our chief instructor, Dr. Ragini. I have got the two presentations, but I will combine few so that the presentation can be complete. Two presentations together, I will complete it. Basically, my presentation is on the hard cataract and my second presentation is on the hypermature cataract. So if time permit, I will now cover the white cataract, and if time permit, later on once I come from that place, I will cover the hypermature cataract. So I think in the era of the FECO, I am not having any financial interest with any company, but they should pay for the association when there is a conference. So that we always ask them. And see now, this is the cataract that I am doing. And see here, the rhexis I am doing. Now, whenever you are doing the rhexis in such cases, it goes in the periphery. And always remember, see, this is a slightly larger rhexis. Why? Because if the bag is small and when you are making the pieces, then the bag get teared from behind. It means posterior capsule side. And so, if the bag is larger, it opens in front and the pressure is then distributed in front, and that doesn't go on the posterior capsule. So to avoid the pressure on the posterior capsule, we should do slightly larger rhexis in such type of cases. You will see now how I am handling this case. See here, I am going down. You will see my tip, it properly goes down, not horizontal, slightly slanting. And then I say, see here, these are the fibers behind. So these are the leathery fibers, and unless and until you separate those fibers, you should not go to the piece. So see here again, what I am doing is I am completely separating the piece, and once I separate the piece, then see here again. So the piece is separated, and once that is separated from this other piece, otherwise the emulsification of the FECO, this nucleus piece will be difficult, and when the last piece remains, go slow and complete the FECO emulsification. So such type of grade of cataract can be so such type of मी एक presentation करू देतो म्हणून सांग. So now see this. Now when you see such type of calcification, in such situation, also the dilatation of the pupil is difficult. Now here, see, I am doing the rhexis, and once I have done the rhexis, now it is a whitish type of cataract, whitish. And you will see the iris repulsion. Can you see this? So the patients who are on the prostate medication or some other systemic, see the here, again you see, and then see what I have done is I have done a trench, proper trench, and after doing the trench, then after that I am operating. See here again. So whenever, see here, so once you are doing FECO emulsification, the separation of the piece up to the center. Separation of the piece up to the center is very important. Now this patient is having the neck movements, and in that I am operating. So you can see the patient is moving. So, and here you can see I am taking care of the iris and completed the FECO emulsification. So you can use anything which is better in your hand. You can use a continuous mode, you can use a high vacuum pulse mode, or multi-burst or burst mode. So these all modes you can use, but you must be well conversant with what you are using for the phacoemulsification. That is what is in your hand. Now see the direct chop. Now see, whenever you are doing the direct chop, see here, in this, if there is a whitish element, whitish, if it is a brownish element, don't go for the direct chop. If cataract hard with the whitish element, then that, though it is, you can see it is brown, but yes, because of the whitish appearance, you can see, I can do the chop here, you can see the, and every chop, see, what I am doing is separating this gradually up to the center of the nucleus. See here, and see the chopper, then I am holding the piece by my phaco, and then I am separating it by my chopper. So whenever you are separating it, so you must separate it properly, and once that is separated properly, then the emulsifying one piece is not difficult. So here you can again see the another type of cataract, and see here how I am doing is, here you can see it has buried inside, and once I buried inside, then you can see my tip of the chopper, and then you will see the separation is possible. So piece, your tip should go down slightly. If it is parallel, horizontal, then there is it slips. So movement of the tip should be slightly down. And see the chopper, see here, whenever you are putting the chopper, see again. So like this. See now, movement is down, going down, so it goes in the substance and then the chopper. So the chopper should be not in the same line, slightly on one side, so that the space is there, and by that space we can remove the cataract. See here now. Again, I am rotating, and once I rotate, see here, see how the piece is separated here, because once your tip is inside the substance, yes, Gopal, please come. Your piece is, this tip is inside the substance, then you can definitely chop the piece, and then gradually the last piece is there. You must go very gradually for the last piece. So now now this is the, you can see now, gradually you have seen the grades are changing. Now here it is slightly harder than before. But again you will see the rhexis is slightly larger. So that is very important. If you do the small rhexis, then the PC tear is inevitable. See now here. See, it is buried in the tip, in the substance. And once you buried in the, see here, again I bury in the substance, see here. And once I bury in the substance, then the chopper will separate it. Sometimes it slips, again you will have to separate it. And once you separate it, see again, I am burying it, see my tip is going down. And once it goes down in the substance, then only the chopper, because that time the piece is now here. So you stabilize the piece by the tip of the phaco. And once you stabilize that piece with the tip of the phaco, then the chopper separates it. Now you can do 4 pieces, 6 pieces, or you can do 2 pieces, debulk it, and then go for the other 2 pieces. That depends on the convenience that time. So whatever is convenient to you, you can do that time. So that is what, see here again, whenever you are removing these, see here, so you can remove the total cataract here. This you have seen. I think that is, you have seen that.
Case 2
Huh?
Case 2
Nice.
show this picture.
Nice. ठीक है. Then I will go to the take-home message. Then I will present the hypermature cataract. Those are not opening. Stop and chop technique or direct chop is possible, but you must be well conversant for that. Effective use of the ultrasound energy is very important. So use it properly. Now one thing you must have experience how you see your own phaco. Record it and see your own phaco. And with the time, it means don't see it haphazardly, yes, मैंने बहुत अच्छा किया. Don't do that. Record it and see properly in the night. Instead of going on the phone and WhatsApp, if you see the phaco properly, then you will learn more. So we give more time on WhatsApp. So that is better to spend time on phaco, so that next day you can do excellent phacoemulsification. And choose what is effective in your hand. So whatever is effective in your hand, it is not that I am telling so you should choose this. So what is effective in your hand, that you should choose. So thank you very much. Thank you very much.
Thank you, Dr. Lahane, sir. So for showing such beautiful videos of hard brown cataracts, and we always worry whether it will be done or not and whether phaco is possible. But as we see that it is possible, a lot of patience and perseverance can help us do it. Dr. Lahane, sir, is also getting one of the awards, which is the Daljit Singh Oration Award Endowment Lecture. So
तुझा presentation अंत जाईल मी. Now Dr. Ragini, who is the convener of the course, will present the soft cataract. Then we
thank you, sir. So, thank you, respected seniors and friends, Padma Shri Dr. Lahane, sir, Dr. Navneet Toshniwal, Dr. Gopal Arora, Dr. Shirish Thorat. Each one of them is from a different town, but they have the best practices, they have the high-end, and they have patients who are VIPs and patients who cannot afford, and we will all be showing different phaco techniques. So we always feel that hard is very difficult. Of course, no financial disclosure. We feel that hard cataracts are difficult, but so are very soft cataracts. Recently, at one of the conferences in Bombay, I had a very, very soft cataract, and it was very difficult to do stop and chop or any technique in that. So it is as difficult because you cannot grip the nucleus. It is very difficult to chop because sometimes when you try to chop it, you may chop up to the posterior capsule, and the chamber becomes unstable because you don't know what technique we are using, and the posterior capsule maybe sometimes be unstable because there might be a PPC element. So, and a posterior polar cataract, which is a soft cataract, it invites capsular rupture. There is difficulty. There may be either a frank defect or an abnormal attenuation. Even after slit lamp examination or OCT examination, anterior OCT, what you find on the table may be a little different or difficult. So you have to anticipate some PC rents or PC attenuations. Now, in these types of cataracts, the signs of caution will be a thick central plaque, which suggests attenuation, thick opacification in the periphery of the central plaque, which may suggest dehiscence, and a peripheral thin opacification and mottling, which may suggest an intact capsule. Now, this is all very, very theoretical. What happens on the table is, even when you are putting a posterior chamber IOL, a small attenuated capsule may give away. So you have to keep everything standby. These patients with soft cataracts are essentially very, very young. and therefore their expectations are more, their life expectancy is more. It's not that you have to treat the older patients badly, because my parents are 85 years old and working full time, but they definitely have a longer lifespan to live, and you have to adapt in your operative techniques. A posterior segment instrument standby or a posterior segment surgeon standby. Learning anterior vitrectomy as a anterior segment surgeon is very important. A small rhexis gives you a large area available if you want to do optic capture or if you want to put the IOL on the anterior capsule. Hydrodissection free phaco, because the amount of fluid or the hydrodissection may cause a small rent to enlarge, so only hydrodelineation. Low parameters are anyway enough because the phaco, the cataract is very, very soft. So these are the few things. These were the important tips in these type of cataracts which have to be taken care of when you are operating. And then now we will see few videos and few techniques. Various techniques are there. There may be, all of us are surgeons, all of us are doing phacoemulsification. There are no techniques named after us, but we do multiple techniques. As you can see over here, the pupil is fully dilated, but this is a posterior polar cataract. Only hydrodelineation means we are going into the substance of the nucleus to separate it, and we are not doing hydrodissection at all. Now, stop and chop is going to be very difficult here, and we are trying to see how you can manage this. Lifting this, or this is called as the nucleus salute or the flip, because the whole nucleus is soft. It is like one quadrant of a hard cataract, and it is emulsified because no other technique may work. When the cataract is very soft, this is what happens. So as you can see again, when you're trying to do any sort of trenching, there is a crater effect. Because the nucleus is so soft, it goes through and through the substance, and you cannot do stop and chop. And if you try to go into the periphery, you will get a PC tear. So any little bit of trenching you do, it goes through a very deep layer of the nucleus itself, and a crater or a bowl is formed, or a saucer, whatever we name it. And now this is a difficult part, because what you have to do is rotate the nucleus, lift it up, and then emulsify it as a whole, because this could not have been done in any other way. So now the important point to note here is, because we could rotate the nucleus, we could bring it above and rotate it, and so the free rotating nucleus is very important in this patient or in these type of patients, which is extremely important. Now you can see the hydro procedure. This is not a posterior polar cataract, but multi-planar, multi-point hydro procedure, because if you inject large amount of fluid in one plane itself, it's very dangerous. So as you can see over here, the nucleus itself is now a salute. It is rotating well, and after rotating it, you emulsify it completely, because stop and chop is not going to be possible. You can see the large epinuclear plate available here, which can be emulsified in the epinuclear mode, or it can be removed with the AC maintainer and the aspiration cannula which we use, or the bimanual which you can use, as you can see over here. So this is very, very important. And this plane, the epinuclear plate, protects you from getting a PC tear. It can be removed in any way which is possible. Here for the epinuclear plate, you can use a blunt chopper and the manual irrigation or the automated irrigation aspiration. So that's very important. So this is another soft cataract that we will be seeing. This is the same, I think. So as you can see over here, it was difficult to do a capsulorhexis. The rhexis runs away, so you can use either a needle or a Utrastas forceps. Whatever works in your hands to do a complete rhexis is very, very important. Because once you break the rhexis, you break the commitment to phaco, and you're already in trouble before starting the phacoemulsification. This is a very, very young patient where the capsule is elastic and it tends to run away. So using Utratas forceps, a lot of patients positions. Either you can go in and come out again, grasp it at different points, a gradual hydro procedure, and lifting of the nucleus or making the nucleus completely mobile is very important. So we see that these cataract look so easy when you are examining a patient before you start surgery, thinking that it will be so good to do this patient, but it is not so easy. It's very difficult because there is no way that you can divide the nucleus or chop the nucleus. And now once this is emulsified, it's very easy. There will be a large amount of epinucleus and cortex remaining in these people that one must remember, because that is another part which needs to be dealt with. So basically, one has to modify the techniques, learn the technique, or use a technique which is available to you. In this patient, we are making a slightly larger axis, and we will do a proper axis, which is very important, the hydro procedure. To separate and rotate the nucleus and to make it mobile, and then the phacoemulsification. So, and in these patients, you have to be very, very careful to see that your choppers are not very sharp, because they can create trouble. We are trying to prolapse the entire nucleus, rotate it, and then emulsify it, because you may not be able to do a stop and chop. If a stop and chop is possible, and if it is slightly harder, then of course one should go for a standard technique, but it may not be possible at all. So we lift the nucleus and emulsify it. Here the aspiration is stronger than the power to emulsify this nucleus, and it is emulsified. A lot of viscoelastic is used if you are in a supra-iris zone to protect the endothelium. So can I just finish this video? So stop and chop. So this is another cataract where, if possible, stop and chop can be done. This is a rhexis. As you can see, these are soft, so the rhexis is few pupil dilates well, and you can do a good rhexis. Now, this is not a very soft cataract, but this is a grade 2+ cataract where stop and chop is possible. So where you feel that the central part is little harder, and where you can do stop and chop when you are actually doing the phacoemulsification, then one can definitely go in and do the standard stop and chop. But these are the good type of cataracts which are very easy to operate. The nucleus is not very hard. A stop and chop is possible. But extremely soft cataracts, this technique, which is a standard stop and chop, will not be possible. So the first division into 2 parts, and then the second division into 4 parts, and emulsifying each piece. So this is like a dream case where you can do it so easily. You rotate, bring the nucleus towards your phaco tip, and each tip is then emulsified. In the phaco 1, when you are making the first division, the phaco power is more. But here, when you are making multiple pieces, the aspiration is more, so that the phaco pieces can be trapped by the phaco tip, and the followability is there. So basically, there are multiple techniques. Whichever suits you best, whichever works best, keeping the patient safety in mind is important. The safe zone is within the area of the CCC. That should never be left, because in a soft cataract, the periphery is even softer, and 100% invitation for a PC tear. A phaco machine which maintains the anterior chamber, which has great fluidics, is extremely important for a good phaco emulsification, and lower parameters are the mantra for a soft cataract. Thank you so much, and thank you, sir.
Thank you, Ragini. I think it was a very brilliant analysis, this small soft cataract you have shown, and all type of soft cataract. Thank you, because soft cataract is difficult when you are doing a phacoemulsification. And thank you, Ragini. And now I will call upon Dr. Navneet Tosniwal. He is from Solapur. He is the best phaco surgeon. He is teaching phacos to the fellows. And you can come here, Ragini.
Thank you, sir.
And
if there are any questions or anything, whenever you want to
now
take the questions,
he will speak on the different phaco techniques. Dr. Navneet Tosniwal.
Thank you, respected Lahane sir, my teacher, Dr. Ragini. This time, this is the very interesting heading, that different techniques for different grades and types of nucleus. That is the very important type. That soft and hard we consider always. But what is this different type? Now we have just mentioned that sticky cataract, leathery cataract. All this is interesting words are the type. That is the reason this is interesting. I am showing first presentation is a hard cataract. Different techniques means it is just not technique, it is instrumentation, it is the parameter. All are important. I am doing routinely stop and chop technique, and most important part is this central cracking, which Dr. Lane sir had shown that it is always, many times it is leathery, and this is a pre-chopper what I am using, so it is a different something and new tool. You can pre-chop after trench 1 time, 2 time, all the time it is equal pressure. So there is no more pressure on a zonules. This we can attempt till we can crack the central leathery fibers. This is, I think, very important. Then you can attempt with your tool, that is with the dialer, with the chopper, and try to crack it. Most important thing is that there should not be pressure. It is not very easy step, and that is the reason you cannot do directly go and start hard cataract immediately. But once the nucleus is divided into 2 pieces, then what the sir has mentioned, bury the nucleus with the tip. So whole chop is important, but most important is the burying. Chopping is easy, but hold is important, where high vacuum, high flow rate is important for that particular step, and your angulation also. Going down towards the nuclear mass is very, very important. Protection of the endothelium with the good viscoelastic is very important. You can see the cracking is always important, and I think partial cracking is possible and important so that apex can attach with each other and you can remove the pieces brilliantly. So it's the parameter, it's what machine you are using and all that. Madam has rightly mentioned about the different varieties. Soft cataract, you feel it's very easy. It's the most challenging situation in a phaco surgery. Different way to deal. And although it is soft, some of the nucleus are very small. So just you can remove it out with the visco expression. And sometimes when you try to do the delineation, dissection, whatever it may be, now here it is the size of nucleus. The size of nucleus is big, so it cannot come out easily. And here you have to go in to do some procedures. So now I'm trying to lift it out. What the madam had shown, Ragini had shown, that lifting out at a supracapsular plane. But it is not coming out. So another simple view, first just remove the epinucleus which is in the view, make the view clear, and again the stop and chop technique. So soft variety is completely different, and here again the role of pre-chopper. That is very important. You cannot divide this nucleus with your phaco tip chopper, not very easy. With the 2 instrument, not easy. So it's a pre-chopper and you see the perfect crack. Now the most important point is this. Now I am demonstrating with the 2 instruments. They pass through the substance. So you cannot divide that. That is the reason you need a plate-like instrument to do this. Because soft cataract, all-time challenge. You cannot do nice SICS. You have to do phaco. You need instruments. I think that is very important. Again, a hydrodelineation. Lamellar dissection of the multiple layers is the very important in a soft cataract. Here I have done delineation to see, to judge my size of nucleus, what size of nucleus I am tackling, and hold is very important. So this is called as the visco expression of the half side of the nucleus out. We are brilliant SICS surgeon. This is what we are doing every day. So stop and chop means trench, divide into two, lift the half piece with the visco, bring it at a supracapsular plane. This is very important. Don't try to tackle this soft nucleus inside the bag. Mature cataract, this is the microcapsulorhexis forceps, very brilliant tool that work as a needle, that work as a forceps. Try to decompensate the nucleus. That is very important. If it is not full, liquid will not come out, but try to do that. Then microcaesar is important to extend that nucleus and then complete with this forceps. What is the significance of this forceps instead of needle? Sometime it go near to iris, as you see, and you can control with the forceps. Sometime with the needle, if you try, you may touch to the iris and pupil can get small in a difficult situation. Another very important in a mature cataract, you cannot predict the hardness and size. So when you start with the first strokes of the nucleus, you get the idea that, yes, this is my hardness. So this is called as a feel the nucleus. This is another very important point. Then you can automatically go for the safe nucleus management. So accordingly, I will judge that what is my density, because in mature cataract, you cannot see before exactly what layers, how much layers it is involved. Try to go in the center. This very nice groove you can see, divide it into two pieces. Once you divide into two pieces, rest of the things are not very difficult. Lift it out from endocapsular to supracapsular plane, but at the level of rhexis, at the level of pupil, and try to chop. Hold is again important. Chop, these are all the horizontal chops. No need of chopper unnecessarily, continuously. That will give the better phaco-fluidics. That is very important. And tackle the other half of the nucleus. Here I want to mention, no need to rotate unnecessarily, move the pieces unnecessarily. That will give pressure on the bag. So this is what you have to try to avoid it. Not very easy to touch these nucleus at its position, but when you embed in the nice plane, you can chop brilliantly. And already I told, it is not always complete chop, partial chop. Fix the apex to apex. That is very easy to tackle the rest. Otherwise, these nucleus pieces are wandering here and there. So if it is partial, they stay there. You can hit, be in a center, just behind the center, and you can tackle it in very well. So I am very much thankful to Dr. Ragini Madam that the heading is so beautiful that different grades, not different grades, it is a different types of nucleus and how to tackle it. And your technique, your parameter, your instruments, all are important for tackling this situation. And I'm thankful for another point that these different types of nucleus, I have written a second book where when I started writing, I got the 42 different types of nucleus, and I have mentioned in that. And sir has only given the forward for this book, and I am again thankful everyone for this patience reading. Thank you.
Well, thank you, Dr. Toshniwal. That was a wonderful talk, specifying about how you can tackle all the different grades of cataract. As Lahane sir has mentioned about the hard cataract, Madam has told about the very soft cataract. There can't be fixed rules. Of course, you need to follow the norms of it, but then every cataract has to be tackled in a totally different way, like Dr. Toshniwal also demonstrated. So it's a totally different ball game. Every cataract is different cataract, but you need to observe and follow and take guidance from the senior phacosurgeons and do case-per-case basis. Now we have none other than Dr. Shirish Thorad, one of the finest phacosurgeons, to tell us more about the subluxated cataract, how to deal with it.
Good afternoon. At the outset, let me thank our Chief Instructor, Dr. Ragini Madam, for including me into the IC. Hello? What? Acha.
So Dr. Navneet will be hosting the Maharashtra Ophthalmic Society with his LOC at Solapur this year. Dr. Gopal has been the president of the Maharashtra Ophthalmological Society, and Dr. Sirish will be the president next year. They are very high volume phaco surgeons, and Dr. Sirish will be now talking.
So friends, we will be discussing about phacoemulsification in subluxated cataract. There are multiple challenges one should encounter. Most important is to tackle the CCC properly. Challenges of getting proper CCC is most important challenge in this scene. Otherwise, vitreous prolapse, intra stability of back can be tackled easily, but one should see for long-term stability of the IOL. So, there are different grades of cataract. You can divide it into three, like mild, moderate, and severe. In severe, the bag need to fix to the sclera by different types of scleral fixation devices. Now, one should look into matter whether the dialysis or zonulopathy is progressive or static. In case of static, you need to fix the bag. And in cases of progressive, like pseudo exfoliation, we need to fix the IOL, either to the iris or to the sclera. These are the different devices for the scleral fixation. Now, we'll go directly to the case-wise discussion. Now, this is case number 1, where this is a coloboma of inferior side around mild to moderate grade of subluxation. Important is to start the rhexis away from the area of dialysis. Always go slowly into the area of the dialysis. Go slowly and purposefully disinter this rhexis toward the area of the strong zonules so that it comes into the center finally. Capsular hook is the best supporting devices I find in the cases of subluxated cataracts. So once the bag gets fixed, a careful and slow hydrodissection, minimum hydrodissection with the rotation of nucleus is important, and the most important is a slow motion phaco. If you are a direct chop surgeon, it is very beneficial. Now, you just don't add any unnecessary stress on the zonules. Lift the piece slowly, one by one. You should reduce all your parameters of phaco by at least 30%. Once half of the nucleus is emulsified, there is ample space for other nucleus pieces to get out of the bag. So the epinucleus can be dealt with the phaco itself, or eye can be done. Now see the forces of the aspiration. It is always toward the area of the dialysis. So your aspiration should be toward the area of the dialysis. Now once phacosurgery is done, it is now time to fix the bag. Now I have taken out the iris capsular hooks, and with the help of CTR, I am fixing the bag. It is important to give support by second hand with the Sinskis hook and take out all the forces of the CTR onto the Sinskis hook. One can use injector system also. So in this case, I find it is enough support. If there is vitreous, you can tackle with the vitrector with the help of triamcinolone. Now rhexis is small, so I want to enlarge the rhexis. So you should be very cautious while enlarging rhexis in the presence of CTR. Now see the force. I am literally pulling the rhexis on the opposite side, and rhexis is getting propagated forward. So this step should be very slow and cautiously. 3-piece is being injected and case is completed. This is second case of mine, a congenital cataract, more than 180 degree of subluxation. I wanted to fix the bag initially with the help of RC anchor, which is a uniplanar device to fix the bag with the sclera. The principle of rhexis being the same. A small rexis initially, cautiously. Now, where you want to fix the scleral fixation device, just make a groove, scleral groove, exactly in the center of the subluxations. This RC anchor is getting mounted on the 10-0 polypropylene suture, and these 10-0 polypropylene sutures are taken out from the scleral pocket one by one, 1 millimeter apart, with the mounted RC anchor. This RC anchor has got two limbs. You can see two limbs. It is getting inside the anterior chamber with the two limbs. The short limbs to be kept on the anterior capsule and the large limb into the back. Now large limb is going inside the back. And you can see how nicely the bag is getting pulled and getting fixated. Rest of the cataract is like, it is very soft, this thing. So you can, is suffice. And case is completed. This is a back fixation intraoperatively itself. Now this is case number 3, where there is large subluxation more than 180 degrees. This was a traumatic cataract. So I wanted to approach this case differently. So presence of the vitreous is with the help of tricot, but in this case the tricot has gone inside. You can see the tricot has gone into the vitreous cavity along with the vitreous. The rexis is very small in this case. Still I wanted to go ahead with the same rexis. Applied the capsular hooks. Now this is Gupta CTS, the Gupta segment. I wanted to use it intraoperatively. So Gupta segment is being injected into the anterior chamber, and with the help of iris hook, this Gupta segment is giving support to the back. So initial debulking of such nucleus is done by the vitrector, as cataract is very soft, and rest of the soft part is taken out by the phacoemulsification. Once it is done, now it is time to fix this Gupta segment to the sclera. Ideally, it should be mounted outside and should be taken in, but I wanted to approach this case differently. Again, with the same principle, two 10-0 polypropylene sutures are taken out from the sclera into the scleral groove, 1 millimeter apart. And you can see the bag is getting nicely fixated, and 3-piece IOL is injected. This is a final case of mine where there is mild subluxation with the vitreous prolapse into the AC, and vitreous is tackled up with the help of vitrector before starting the phaco itself. With the help of capsular hook, phaco is being done. I wanted to show one complication in this case. You can see the back prolapse, which can be dealt with the CTR itself. So remaining, I wanted to use the same segment in this case. The subluxation was on nasal side. Just you can watch the movement of the needle. One needle.
There are some seats in the front here.
One needle is taken out nasally. These are very long needles. 10-0 polypropylene suture needle are very long. So one needle is taken out. Now watch the second needle. The trailing end of the needle has broken the PC. So this is one of the complications which one can encounter while dealing with such cases. So CTR is in the back, the CTS in the anterior chamber, but still we can use same CTS into the bag. It doesn't need a complete postcapsular rexis in such cases. Vitreous is being taken care of by vitrector and triamcinolone, and 3-piece IOL is injected same way, and case is completed. So, in summary, in such a cases, always start rexis away from the area of subluxation. Implant CTR as late as you can, but as early as you must. Slow motion phaco with a direct top technique is preferable. Closed chamber maintenance is important in every case, and while removing the cortex, the forces will be toward the red glow and scleral groove to be taken at the center of the subluxation. Thank you.
Thank you so much, Dr. Sirish. There were wonderful videos where you showed different devices to manage a subluxated cataract, and they were so clearly visible. Wonderful teaching and great videos. So previously, whenever we saw a subluxated cataract, we were always worried as to whether we'll be able to do only a secondary IOL or in a second sitting. But giving vision to the patients with various devices that were available. Thank you so much. The next speaker is Dr. Gopal Arora. He was a president of the Maharashtra Ophthalmological Society, and he's also a member of the AIOC committee, managing committee, and he is a high-volume phaco surgeon. He will be speaking on non-visco phacoemulsification, and he's demonstrated this technique in live surgeries at BOA very often, sir. Dr. Gopal Arora.
Thank you, Dr. Ragini ma'am, first of all, for making me a part of this interesting IC. First of all, I would like to say that no visco phaco has come as an accident to me. As it has been said, that necessity is the father of invention. That is what happened to me when I had gone to a peripheral center operating in lot many cases, and in the last 2 cases when I asked for the viscoelastic, they said the visco is over, it will take out more than an hour or 2 to get the viscoelastic. So I thought, let's proceed without using the viscoelastic. And that is how this thing came to my mind. Then I retrospectively actually studied that where actually we need viscoelastics. So even before the invention of viscoelastic, cataract surgery was done. So the capsulotomy or other things were done under that air bubble. But the problem was that if you're putting an IOL without a viscoelastic, you're bound to rupture the posterior capsule, which used to happen. And secondly, if you are rubbing it on the endothelium, then endothelial decompensation was a part of the surgery if you're not using viscoelastics. So basically, viscoelastic came as a replacement for the air bubble used to do capsulotomy and lens insertion during the surgical complication, which were the ruptured capsule and the decompensation. Basically, the use of viscoelastic is to create space for doing capsulotomy and to balance the pressure between the anterior and the posterior segment, and to stabilize the tissue, and of course to protect the endothelium. To form the anterior chamber before the IOL insertion, again, is the area where viscoelastics come into picture. And few surgeons use viscoelastics over the cornea to to enhance the visualization during surgery, but that is a relative distant indication. But are viscoelastic totally free of complications? Because we have seen the hike in the intraocular pressure may be very transient because of the mechanical blockage by trabecular network or the antigen-antibody reaction due to trabeculitis. Capsular block syndrome and the distension syndrome leading to pseudomyopia, though transient, again is a possibility. Inflammation, we have seen a lot of infection end of cases, and this visco being the culprit. And of course, we need copious washing. Since we have put viscoelastic, we need to remove it. So what is modern day cataract surgery all about? It's a closed chamber, the smallest incision, the best fluidics, efficient power delivery, and least intraocular trauma. And of course, what you're doing should also be reproducible. So phacoemulsification without the use of viscoelastic, of course, is a possibility. What are the advantages? It's a faster surgical time, less risk of post-op IOP spikes, and of course the biggest advantage to me was the continuous irrigation that you're putting from the left hand maintains the chamber stability, it protects the endothelium, fixation of the eye, because I use irrigating cannula like the irrigating one cannula from the left hand side, it helps me fix the eye as well. And of course, in toric IOL, since there are 3 steps in toric IOL, the last step is actually making the final alignment after you remove the viscoelastic. So that step can be totally eliminated because you're not putting the viscoelastic. Post-operative data shows no significant difference between the 2 groups in endothelial cell loss. So phaco without the use of viscoelastic is safe and effective. But there are few reservations. If it's a very hard cataract with a compromised cornea, one should avoid. If it's a high hypermetroph with a shallow anterior chamber, again one should. Intumescent cataract, we know that the rexes give way. Small pupils, because we might have to use the iris hooks. Pediatric cataract, for simple reason, we aim at a 3 millimeter rexis and it gets converted into 6 millimeter. And if there are complications like the PC rent or IOL exchange because of the broken haptics, you need to use viscoelastic. But those contribute to not less than 15 to 20% of your cases. This is just a video I would like to show you about how we can go ahead by doing a phacoemulsification without using a viscoelastics. Normally, these days I make a left side port first with an MVR blade. Yeah, I'm making it with the right side. So normally you make a 2 side port with the MVR or lance tip blade, whichever you're comfortable doing with. And after you have done these 2 side port, the first thing that you need to do is that maintain the chamber by putting one irrigating cannula from the left hand side. As I told you, it serves 2 purposes. One is it maintains the anterior chamber, it fills the anterior chamber. Second, you can hold the eye with the left hand because it's done under topical anesthesia. In any case, whether you are adopting this no visco technique or not, but you can actually hold the eye with the left hand throughout your procedure. In a topical case, this helps wonderfully. The trick here in doing a capsulotomy is that you need to just change the direction of your irrigation so that the rexis flap is everted. So just this irrigating cannula directing the fluid towards the capsulotomy should be the main aim of directing the anterior capsular rim. Again, it should be everted. Now you just need to do hydrodissection from the side, and with the Sinskey hook you need to separate the nucleus from the epinucleus so that the nucleus is free. Now is the area where again you would require viscoelastic because you're taking out the instrument. So you just hydrate the 2 side ports so that the anterior chamber is again formed and filled. Now once you have done this, before you actually put in the phaco probe, you need to put the irrigation on. Never the phaco probe should enter with the irrigation off. So with the irrigation on, you can put in your phaco probe. And now it is just like any other phacoemulsification procedure, whether it's a direct chop or stop and chop. That's the technique of your choice which you want to adopt, as have been emphasized by the previous surgeons. So that is an individual choice, and you can do the phacoemulsification from what best works in your hand. Now after the nucleus is removed, as you can see, the chamber is already formed. Now there is hardly any role of filling the anterior chamber with viscoelastic because the chamber is already deep. So once you have removed the main crux of the nucleus, then you do the irrigation aspiration. I am more comfortable doing it with the irrigation aspiration cannula because I remove the cortex from one end. At the same time, I do the polishing of the undersurface of the capsule. I just change my hands and remove the cortex on the other side, and I do the polishing of the undersurface of the anterior capsule from the same side. Now again, you just need to slightly hydrate the side port so that the chamber is formed. Now believe me, this is something I have been doing throughout my life. I mean, hydroimplantation of the lens is something that everyone should adopt from tomorrow because it works in everybody's case. It's just a matter of practice for 5 to 10 cases. You just need to put the BSS or saline, whatever you're using, from every end of that cartridge. Over the cartridge, from this side port, from this port in the cartridge, again you can fill it from the other end of the cartridge. So fill in as much as BSS because the moment you put in, it's going to leak. So, but you try to fill it as much as you can, and then try to do the hydro implantation of the lens, which I call, and it's a very easy way of doing it, whether it's a hydrophilic or the hydrophobic lens. And as you can see, again, the left hand works wonder in fixing the eye. The patient cannot move his eye because I have fixed it with the irrigating cannula, and I put the lens, and it is under the irrigating fluid. And I just dial it with a Sinskey hook. The lens goes in the bag, and it fits in very well. Now what you need to do is just remove whatever debris you can because there's no viscoelastic, nothing more to be removed. You can just hydrate the 2 side ports and the main incision if you wish to, and the surgery is completed. So to summarize, there is less post-op intraocular pressure spikes, surgical time is fast, fixation of the eye to me is the biggest advantage. At least you eliminate one area which is going to cause some contamination. And this is my favorite slide, which Einstein, I really am awe of this slide. So thank you so much for the patient hearing.
Gopal, thank you very much. I think it was a very nice presentation, and no visco lens. That is a normally I do in the ICL. It means when I am doing for the this phakic IOL, I am using that. But you can use some visco. If not, you can without visco also. That is good. So thank you. Come, and now I will invite again Dr. Agini. She is going to speak to us on the intumescent and hypermature cataract. Ragini.
Thank you so much, sir.
खाली जा ना.
खाली जाते. Excuse me.
हे कर. Escape करो.
So hypermature cataracts are definitely difficult to manage. Okay, thank you. Thank you so much. So what are the challenges when you are faced, that you face in a hypermature cataract? They are multi-pronged. So there is no fundal glow. The rexes, when you do, because the cataract is so intumescent, can get extended. There are more chances of nucleus drops if it can be a complicated surgery. The IOL can get decentered. There will be endothelial damage because of your manipulations. And there are chances of posterior segment rupture. So how can they be tackled? The use of trypan blue can be used to manage the no fundal glow. Use of rexes forceps can be done to make a good rexes. We need to have an anterior vitrectomy and standby lenses available in case of an untoward complication. VR surgeon referral is extremely important for a nucleus drop. And you have to use a good viscoelastic to protect the endothelium. Whenever there is any decentration of the IOL, so if there is a proper bag, the chances of decentration is very, very less. But if it is there, then intervention will be necessary. So we will see a few cases of hypermature intumescent cataract. As you can see over here, this patient not only has a mature cataract which is intumescent, but there is a calcification in the anterior capsule, means whether there was any trauma. The capsule is always stained with trypan blue, which makes our life much easier because there is no glow. Otherwise, it would be very difficult to do a capsulotomy. It should be away from this area of calcification. And as you can see, if you have difficulty in doing the rexes, if you see the initial part of this video, I'll just show again that we are using a needle here to do the rexes in this video, and you see that there are chances of this rexes going out. So now we have changed to this forceps. So it's okay to use a combination of these two to do a good rexes, because if you feel that you have better control with the forceps, then to come out, put viscoelastic again and use a forceps. Micro forceps from Epsilon are also available, which can be used to do a good rexes without too much of manipulation through a small entry. As you can see over here, there is no epinuclear buttress. The nucleus is vertical, and now there is no hold over the nucleus. So that is very important, that there is no epinuclear buttress. You have to have a machine which has a good followability. Followability means the ability of this phaco to hold itself to the nucleus, and then it can be divided. If that is not there, the nucleus will keep on floating around without being chopped. So you should have enough power to hold this nucleus to the phaco tip. Once it is held, then with the chopper, it can be chopped into multiple pieces and it can be emulsified. So as you can see over here, you may not end up with a proper finesse with techniques and all that, because the nucleus is floating around. So you have to use the chopper, which is a very, very essential tool to help you feed these pieces, or to hold the pieces, or to control the pieces while doing the phacoemulsification. Now, just wait. If you saw the last part of this case, one has to wait before coming out, otherwise there will be a surge. This is the second patient. The tunnel is very, very important. A complete and the correct size tunnel is important, otherwise the fluid leaks and then there will be problems. As you can see, this is definitely a hypermature intumescent cataract. We are doing a rhexis. Some amount of milk will escape the cortical milky material and one has to tackle it. Doing the rhexis, having a lot of patience during the rhexis in these cases is extremely important because the nucleus is very intumescent and the capsule consistency may be different. Here also again we have used two instruments to complete the rhexis. First the needle and now the forceps. It's okay to do it because what is important is a rhexis. Now all the milky fluid is aspirated and you see a large nuclear cataract inside. Once the cortical milk is removed, you embed the nucleus with the phaco chopper and you do a straight Nagahara's chop in this patient. If you cannot do it, then you trench it. So what is important is that you try this, for this Nagahara's chop, using a high ultrasound and embedding the nucleus and using the chopper effectively to make that chop is extremely important. The nucleus keeps on rotating because there is no epinuclear support and nothing. One has to see that when you chop, the posterior fibers which are interdigitating are also chopped. The nucleus is very large, so multiple small pieces are made before you emulsify it and gradually till the posterior layer of the interdigitating fibers, because if the nuclear pieces are not completely chopped, they will get entangled and the sharp pieces may tear the posterior capsule. So a complete chop is necessary. Once you have, then you can start debulking by emulsifying one piece and then one piece at a time the nuclear pieces are emulsified. Here you can see that the nucleus is bulky so that more than 4 pieces are made because even the 4 pieces will be very, very large. So multiple small pieces emulsification is important. And at the end of emulsification to wait before withdrawing so that there is no surge. These are the important points to remember. One more intumescent cataract. The availability of good quality Indian intraocular lenses, good phaco machines of the Indian make it possible to do phacoemulsification even in this. So this milk needs to be tackled before you aspirate it like directly by using this syringe on which the capsulotome is mounted, and then use a Utrata's forceps or microforceps to complete the rhexis is very, very important. Blue Rex is definitely a boon for us in these hypermature patients. And once the rhexis is complete, it is good to do a phacoemulsification because otherwise, with no epinuclear buttress and the anterior capsulotomy extending, it would be very, very dangerous for us. Now to chop this nucleus, you have to use a modified central horizontal chop. Horizontal, vertical, what you call it, what is important is your machine. So whenever you buy a machine, whenever you are understanding the fluidics and the dynamics of the machine, the followability of the machine, the complete proper use of ultrasonic power in that machine and the chamber stability, these are the factors which will make a big difference to the success of this case. The chamber stability is very, very important because otherwise if there is surge, then you cannot manage this patient. There is no epinucleus, there is no cortex. What is there is only this hypermature cataract. But phacoemulsification is possible in these patients. So this is a hypermature cataract, and what we will be showing here is what is not to be done. So you go in and try to do the rhexis in this patient, and you can see it's difficult to do the rhexis because probably there is a soft cataract inside and you are trying to do a rhexis, and while doing that, so much of the cortex and the liquid cortex is mobile in this patient. So this itself gives you an indication of the danger or the problems that are going to occur occur. There is crumpling of the capsule, as you can see over here, which is making the capsulotomy and the capsulorhexis very, very difficult. And you can't do it because it's crumpled. And it's hypotonic because there is some amount of trauma or subluxation in this patient, which you can make out only when you are doing the rhexis, because it would be very subtle or it would be in the periphery. So you use the forceps to do and complete the rhexis and to manage it. And you can see that there was a traumatic cataract, which that fibrotic element which is visible here, which may not have been visible when you are starting the case. So the hypotenuse capsule gives you an indication of the problems that are present. So this is another video of a hypermature cataract. Again, the tunnel, the correct sizing of the tunnel, the Blu-Rex stained capsule, and the capsulotomy. These are very, very important preludes to a proper phacoemulsification, which cannot be taken lightly. Now, as you can see, this is intumescent, and your cataract, the rhexis is already extending, and it is progressing towards an Argentinian flag sign. And now you have to modify this in such a way that you have...
1 minute. Now see, this Argentinian flag sign has happened. Slow karo usko. It is just because, see, slow karo usko. See what happens, whenever you go and tear the anterior capsule, if you tear in the straight line, in such cases, straight line, then that is going to be Argentinian flap. First, you can aspirate the fluid, reduce the pressure, one. Or you can do a small rhexis in the center, and then you can do the large rhexis. Or if you are doing, then the curvilinear. It means curvilinear tear in the anterior capsule. So unless and until you do that, it is going to be Argentinian flap sign. That is just because we are having the habit like this or like this. So that habit should not be there when there is a fluid in the lens. So remove the fluid by the lens. Before that, they are removed by the 26 gauge number needle. They are removed fluid. It was subluxated. The zonules were weak. So that will help you. The rhexis was done there. So in such cases also you aspirate the fluid, reduce the pressure inside the behind the capsule, or otherwise make a small rhexis in the center, or curvilinear incision. Curvilinear. It should not be linear incision at all. Go ahead.
Yes, sir. So very true. So one has to be careful, otherwise you land into this complication. So one has to be very careful and very conscious while doing.
Now see, wait, see the flap. You can see the flap there. Wait, Ragini.
Yes, sir. Yes.
So that flap is moving. Now this is a Rohit Om Prakash who told about this sign. If the flap is moving, it means there is no PC tear. If flap is not moving, there is a PC tear. So that flap movement sign is very important when you want to do phacoemulsification. Otherwise, you should not go ahead at all, because that is a PC tear. Now here there is no PC tear. Only thing is that there is this Argentinian flap sign. Extension is done, but no PC tear. So if you do consciously, cautiously phaco in this, you will succeed. Go ahead.
Yes. So very important tip, sir, and it is also important. So this is what sir was saying, that this Rohit sir has given this important tip to us, and one must give credit to the person who helped us. So these, more than the good videos, these are the videos which help save ourselves when we know and learn from the mistakes of others, and trying to do a safe phaco here, because we know that likely that the posterior capsule has not been damaged, the tear has not extended. And then to complete this, so basically the take-home message is to use the die for the capsular tane, use a sharp chopper, stop and chop technique or Nagaharas, whatever works, effective use of ultrasound energy, which is very important, and to choose what is effective in your hands. I would also say that the technique is also important. If phaco is not possible, then SICS also works. One must not feel inferior, but the patient always comes first. Thank you, sir. Thank you so much.
Thank you, Ragini. So if someone want to ask any questions, we have...
Presentation is lecture.
hypermature spinous. Hypermature is already covered in the intumescent. So I think our type of cataract, it may be a soft cataract, then the hard cataract, hypermature cataract, nuclear cataract. Every cataract can be tackled with phacoemulsification, and the team has shown you the different techniques which can be used, different types of machine. You can use any type of machine. It is not required that it should be only higher end machine. Any machine you can use, only you must know that machine properly. And once you know the machine properly, then you can do phaco properly. So for that you will have to study machine also and see your videos. Once you see your videos, whatever you have done the mistakes in the past, you will not do in the future. So thank you very much. Thank you, Dr. Gopal. Thank you, Navneet. Thank you, Siris. Thank you, Ragini, for this, and everybody for attending in such a large number. Thank you very much. We will have one photograph. Is there photographer? There. देखिए